All right, Chapter 32, Part 2. So some of the problems with doing tumor marker measurements. There are multiple tests out there and multiple different kits, and there is a lack of standardization. Between the kits. So for example, linearity can be very different from one facility to the next. So it is good to stick with the same assay performed at the same lab. So we should serially evaluate tumor markers because that's how we are helping in the monitoring of a patient. But we should use the same kit over a long period of time if possible, because that's going to be a better reflection of how the patient is doing. Instead of having one test here and one test there, their normal ranges are all different because the methodologies might be different. So how do we measure these levels? Well, they can be measured biochemically by chemical reactions, radioimmunoassay, enzyme immunoassay, or by molecular methods. Immunoassays are the most common measurement method available. And markers on the cell membrane or in the cytoplasm are measured by immunohistologic or immunocytologic techniques. So these would be tests that are performed in histology. So we might be working alongside the histology lab with some of these types of cancer. Sample types are typically serum. It's almost always red taps that we're collecting. You centrifuge it as normal. If you're not going to be the one testing it, if you are sending it out, specimens can be refrigerated. Some require freezing, but patients don't have to be fasting. Typically, it's not a specific time that the test has to be ordered at, so it's ordered and it just needs to be mainly collected that particular day. Alright, so again, immunoassays are the most common, but challenges associated with that. Markers are often above the linearity, meaning that results are outside of the reportable range for the instrument. So a lot of times we're reporting results as greater than this, greater than that. Well, if it's greater than this, greater than that, and your manufacturer indicates that you can't dilute a test and then run it again, so you don't have an exact amount, that can be hard then when we're trying to monitor a patient. If the results are always above the line, we can't tell if it's increasing or decreasing. Also, hook effect is another challenge. Where excessively high marker concentrations will result in a falsely low result. And this is due to antigen excess or antibody oversaturation. So what happens is they can't make the sandwich and there's a decreased signal. Occasionally we can dilute and repeat if this is suspected, like if it's happened before, or we know this patient normally has a really high result and suddenly, mysteriously, it's very low, we would maybe think that this could be the case. Heterophilic antibodies are cross-reacting antibodies, and those are things that can affect our results as well, because those can react and we can have false increases or false positives because of this. Icteric samples, lipemia, hemolysis, and antibody cross-reactivity can cause interference. So we should avoid hemolysis, lipemia, and icteric samples, in addition to using serum most commonly. High-performance liquid chromatography, or HPLC, detects small molecules like endocrine metabolites. So they're most widely used to detect catecholamines and their metabolites in plasma and urine. So if you remember the metabolites with catecholamines, they are VMA and HVA, the vanilla mandelic acid and homovanillic acid. So analytes of interest are separated from the plasma or urine via extraction, run over a column, and separated by physical characteristics. So they're separated by things like charge, size, and polarity. HPLC can be used to detect neuroblastomas, pheochromocytomas, and carcinoid tumors. In neuroblastomas and pheochromocytomas, what we're looking for are homovanillic acid and vanilla mandelic acid. And in carcinoid tumors that secrete serotonin, and this can be in the small intestine, appendix, or rectum, we want to test for 5-HIAA, which is a metabolite of serotonin. 5-HIAA. Then we have immunohistochemistry. So test tumor markers that are detected directly within solid tissues by collecting a fine needle aspirate or a biopsy from the patient. A slice of tissue is placed on a glass slide and incubated with specific antibodies in a solution to detect the presence of antigens using colorimetric or fluorescent secondary antibodies. So those are in histology on the tissue itself. Enzyme assays won't really be any different than other enzyme tests. It's the same as what we've talked about before. But the detection of elevated circulating enzymes generally cannot be used to identify a specific tumor or the site of a tumor, with the exception of PSA, which is found exclusively in diseased and benign prostate glands. And before the use of immunoassays and oncofetal antigens was common, enzyme detection was widely used. So some examples of enzymes that can be used as tumor markers: alkaline phosphatase can be used for bone, liver, leukemia, and sarcoma. CKBB can be used for prostate, small cell lung cancer, breast, colon cancer, and ovarian cancer. LD can be used for liver, lymphoma, and leukemia, and PSA, of course, is used for prostate cancer. So some of the individual tumor markers. Alpha-fetoprotein is synthesized by the fetal liver, so this would be oncofetal. And it can re-express in certain types of tumors. So AFP normally functions as a transport protein and helps regulate oncotic pressure in the fetal stage. In adults, AFP is used to diagnose hepatocellular carcinoma as well as germ cell tumors. So for example, testicular cancer, where they are producing AFP. Carcinoembryonic antigen, or CEA, is a part of a large family, and it's involved in apoptosis, immunity, and cell adhesion. And it is thought that CEA may be involved in metastasis. So it's expressed during fetal development, so that makes this one oncofetal as well, and this one is an oncofetal antigen. Let's just throw that on there, antigen. And then it can re-express in tumor growth. And it's typically used with a combination of histology and then TNM staging. So those three things all together. And it is a very good tumor marker for colorectal cancer. But it's also increased in lung, breast, and GI tumors as well. CA is used for prognosis, post-surgery surveillance, and to monitor the response to chemotherapy in patients with colorectal cancer. So methodologies with CEA, it was historically we used polyclonal antibodies, and now it's monoclonal anti-CEA antibody. And it's essential that the same assay be used for serial monitoring in these patients with colorectal cancer. CA-125 is used to monitor ovarian and uterine cancers. CA-125 is a monoclonal antibody produced against the ovarian cancer cell line. It's also useful in detecting early-stage ovarian tumors and in monitoring treatment without the need for surgical restaging. So we don't have to get histological specimens to stain again to restage the disease. CA-125 can be used annually in women with family or prior history of ovarian cancer. So it's not for everyone, but if you have a family history or you yourself have had ovarian cancer, then CA-125 can be used to kind of watch those people. Levels of CA-125 do correlate with cancer staging. So stage 4 is associated with the highest levels of CA-125. And increases can be seen also with endometriosis. And that's the end of part 2.